Good morning, everybody. Justin Dunaway here with the Institute of Clinical Excellence. Welcome to another episode of PT on Ice Daily Show. Before we get started, I want to do a quick thank you to Colorado in Motion for hosting our spinal manipulation seminar over the weekend. It was an absolute blast, a pleasure to work with everybody out at CIM. It's always fun to teach in a room of such a concentration of high performers. Really had a blast this weekend, so again, thanks for having us out. All right, so let's get into it. Today I want to talk about an article that was just published in November by Adrian Traeger that's been getting a lot of buzz in the social media circles. It's called The Effect of Intensive Patient Education versus Placebo Education on Outcomes in Patients with Acute Low Back Pain. I'm going to throw a link to this article and some of the supporting information in the feed below at the end of the podcast. But so the goal of this article was basically they said that many people that have acute back pain transition to chronic pain. So the question is, if we add intensive education to care already being given, will that alter the course? Will that shift the path and kind of eliminate these people from transitioning to persistent pain? We know that roughly a third or so of people that have back pain will go on to have persistent back pain. So we've got to start to figure out how do we catch these people and shift them so they don't end up on that path. And this is a nice study to start looking at ways to do that. Unfortunately, this study's getting a lot of play in social media right now because this is not a win for the pain neuroscience education crowd. This is this didn't turn out well for the education group. So let's go ahead and talk about this for a minute. So what they did is they took 202 people that had acute back pain, as defined as less than 6 weeks, and they measured that, or they took a bunch of people with acute low back pain, less than 6 weeks, and measured them to see if they were at high risk for transition to persistent pain using a thing called the pickup tool. And this is it's a 5-item tool that it's validated to predict the transition from acute to chronic pain. I'll throw a link to this as well in there so you guys can check that out. Maybe that's something you want to use in your practice. So they took a bunch of people with back pain, screened them to see who is at the highest risk to transition to chronic back pain, and then they pulled them for the study, 202 of them. So everybody in the study got usual frontline care plus either intensive pain education or placebo education that was delivered in 2 one-hour sessions. So the pain education group, it was basically information pulled from Explain Pain, Mosley's text, but there were 3 main points to the education. It was to reframe unhelpful beliefs, give patients a neurobiological basis for acute and chronic pain to help them understand what was going on with their symptoms, and to evaluate the understanding of these concepts and discuss techniques to promote recovery. Right? So, at the end of the study, what they found is that it's at the 3-month mark, there was no difference in pain between the actual education group or the placebo ed group. And the placebo ed group, basically the therapist went in, and this was just a control for time with the therapist. So the therapist went in, listened to the story, reflected, talked to the patient, but gave no education whatsoever. So just interacted with him for an hour. What they found is that at 3 months, there was no difference in pain between the two groups. On average, they went from a 6 to a 2 on both sides of the coin, so no change there. In disability, at 3 months, there was a small improvement in the real education group, but at 6 and 12 months, everybody washed out the same. So the conclusion of the study was this. Adding 2 hours of patient education to recommended first-line care for patients with acute low back pain did not improve pain outcomes. Clinical guideline recommendations to provide complex and intensive support to high-risk patients with acute low back pain may have been premature. So again, not a win for the education crowd, but I want to dive in a little bit deeper because in my head, education is so incredibly important. I just think that we're still struggling to figure out the how, when, where, and why. So on the front end, we've got a few questions here. What is the goal of patient education? Because one of the big questions is, do we even need to be educating patients in acute pain about pain? Because the real problem exists when they're in chronic pain. But so we got to figure out what's the goal of the education. Is the goal of education to reduce pain in the short term? Is it to change disability in the short or the long term? Is it to reduce downstream costs? Is it to give patients internal locus of control, understanding of resilience, self-management skills, so that when things crop up, they don't rush into the system. They have tools to self-manage. And I think that that's really important for us to define as we step back and look at what are we really trying to do with our education. When I read the study, another question that I really want to know is what's happening at this first-line care, right? Because all of these patients are receiving first-line care from their acute back pain with their usual provider. But in the study, it's sort of a black box because the researchers, we don't know what's happening with that individual person and their clinician. We just know that the clinicians are supposedly following the guidelines, and then they're getting this educational intervention. What's a really important thing for us to understand as we try to educate our patients and change beliefs is that the message has to match throughout. So if you walk into the room and I give you a 1-hour education piece on the neurophysiology of pain, and pain is not damage, and some stress reduction techniques, and some mindfulness stuff, and some really resilient stuff, and really advise you to remain active and progressively build and graded exposure, and all the really good stuff. And then you're going to another provider, and the message that you're getting is more fear-based, more biomechanical, it doesn't match the education. What Darlow showed us in his Easy to Harm, Hard to Heal article is that when patients are presented with 2 sets of competing information, they're going to gravitate, they're going to self-select towards the information that reinforces their already held negative beliefs. So I can give you the best education on the planet, but if somebody else is reinforcing that fear that already lives in your head, you're totally going to ignore what I'm telling you. So it's really important for us to understand not just our message, but what other messages are the patients being bombarded with throughout the course of care. Next, this is another really important piece of education. Were we educating our patients, or were we lecturing to our patients? And it sounds like a syntax thing. It sounds like I'm just being picky on words here, but let's really think about this. If I'm educating my patients, then beliefs and expectations and ultimately behavior should and will change. If I'm blasting you with an hour of information and then sending you loose, do I really know if I change the way you conceptualize the stuff going on in your body? Do I know if I change your beliefs enough that it gets you to behave differently? And then that behavior change is the thing that keeps you out of the system downstream. So in this study, the lecturers measured pain catastrophizing scale, kinesiophobia scale, neurophysiology of pain questionnaire, pain beliefs questionnaire, a lot of really good stuff to understand where the patient's beliefs and expectations live. But they didn't report if those things changed. And in the supplemental article, they said that information will be coming in another study. But what would be really helpful for me to understand how well this intervention worked is if the education actually educated somebody. We wouldn't do a study saying that, bench press strengthens the pec major muscle and then give you 4 weeks of bench press, measure your baseline strength, and then never check back in on the strength. To know if we actually educated versus lectured, I need to know 4 weeks from that intervention if your PCS changed, if your kinesiophobia scale changed, if your neurophysiology of pain questionnaire changed, if our educational baselines changed, where in this study the main outcome measure was pain. I feel like the main outcome measure should have been change in these measures and then long-term disability. And we should look to see if the people whose beliefs and expectations changed, their pain and disability changed. That's the stuff that I think is really important. All right, so the last question I have for this article is this one: are the patients that are at the highest risk to transition from acute to chronic pain the ones that are the most appropriate for intensive pain education? And I think the first thought when we hear that question would be, well, yeah, absolutely. These are the ones that need it the most. And I'm not disagreeing with that point. Yes, these are the patients that need the education the most. But are they appropriate for the intensive education? Meaning, is this a dosing issue? We're really good as physical therapists, we're really good at dosing and grading our physical interventions. When a patient walks in the door, we can evaluate them, figure out where in the gym we're going to start, and progressively load and grade that over time. But it seems like when a patient comes in and they need an educational or psychological intervention, we don't necessarily understand how to evaluate, grade, and dose that. We just blast them with everything day one. It would be the equivalent to every patient walking through the door and we're starting with 50-pound deadlifts off the floor. You know, some patients, that makes perfect sense. Other patients, we're going to start doing some supine glute activation stuff, and we're slowly going to build to maybe a month or two down the road. Now we're doing weighted deadlifts off the floor. We've got to start to approach our educational interventions with our patients in the door in the same manner. The patients that are ready for it, let's hit them with both barrels. But the patients that have had 20 years of pain, that are highly psychologically irritable, that everything thus far has failed, that are terrified of their bodies, that have got all ththese maladaptive beliefs and negative expectations in their head, walking in the door and shooting them with everything you know over an hour for 2 sessions may be too much for that patient, and they may not grasp any of it. They may dig in and defend. So it's really, really important for us to understand where our patient's at, what they're ready to hear, and dose and grade the educational interventions that match the patient in front of us. So, at the end of the day, I really think that research like this is really important, because education is really important, and we don't have a lot of stuff studying when to apply it, at what dosages, at what patient populations. And while this study wasn't a win for neuroscience education, it does tell us some stuff. It does tell us that maybe we're just looking at it wrong with this patient population, right? So what we need to do, well, the first thing that we've got to remember off the bat is we can't throw the baby out with the bathwater on this one. We have to realize that even though this study didn't show that intense education changed the course of acute pain patients, we've got to remember that every chronic pain patient was once an acute pain patient. And more over time, acute pain patients are transitioning to chronic pain patients. So we've got to be able to figure out what's going on and how we get those patients off that path. And I really, really believe that it's getting patients to understand and think differently about their bodies, about their course, about their injuries. And we've just got to find a better way to do it. So we need to be thinking about how we dose and grade our education. Right? If our goal is progressive behavior change, then we have to set the intervention up for success. We're not going to eat all of our food for the whole week on Monday. And if we're going to do a strength training thing, if we've never lifted weights in our whole life, we're not going to get in the gym, crush everything that we can think of for the next 2 hours, and then expect to be stronger and feel good about it on Tuesday, right? That's not how we do stuff, and we got to look at education the same way. We can't preload everything a patient needs to understand about pain, their self, their resiliency into one to two sessions and expect to reshape everything that they've believed for the last 30 years. And understand that even if they're an acute pain patient, they've got 30 years of messaging from our culture saying that pain is damage and all the negative beliefs and expectations we have. When you ask patients about their body, their beliefs are maladaptive. We know this stuff. So let's not throw the baby out with the bathwater here and realize that it is so much easier to move someone away from the cliff than it is to fish them out of the water, right? I believe really strongly that there is a place for education like this. There is a place for intensive 1 to 2 hour sessions of giving people a lot of really good information. But I don't think it's in the clinic, and I don't think it's with the clinical population. I think that this type of education makes sense in group settings for the general public. This is a public service announcement. This is the stuff that we need to start sprinkling into the water in the community before they ever end up in the clinic, before they ever end up in pain, so that when they have that painful experience and they walk into the clinic, now they're primed to hear the good message and we can start driving them forward on resilience. realize that with our acute pain population, we have an opportunity. We have a responsibility. We need to dig in. We need to see if maladaptive beliefs and negative expectations exist in these patients. And when we identify them, we have to work to change them. Just because this study said that the intensive education doesn't change the course of care doesn't mean we need to stop trying to get patients to understand their bodies better. We need to, they're going to be in the clinic and we're going to be guiding them through this acute nociceptive dominant healing process, getting them to move better, getting them to be less afraid, getting them to progressively grade back to what they've been doing. But while they're there, while they're on that path to getting better, we've got to be thinking about downstream. We've got to realize that if we've got a patient on our table that's afraid of their body, that's afraid of their injury, that feels like they need a thing to fix, they've got an external locus of control, we have got to start sprinkling in education at a dosage that makes sense for the patient. Start planting seeds. Start giving them things that they can do next time this happens on their own, with the goal of trying to get them to not end up back in the office, with the goal of trying to give them an internal locus of control and understanding that the body has an amazing capacity to heal, that it's resilient, and that as long as we keep moving, keep doing stuff, and progressively moving forward, much of the stuff that people go to the clinic for is not needed, right? That's our goal with our acute pain patients. We have the opportunity, we have access to them. Let's teach them how to not need us in the future. So, when we're thinking about the education we provide, we've got to realize that that we can't just throw knowledge at somebody, especially when they don't believe the stuff we're teaching, right? We've got to, if we really want to change their beliefs, if we really want to change their expectations, if we really want to change the understanding of their bodies, their pain, we want to reduce fear, we want to promote resiliency, we want to give people back their internal locus of control, teach them tools for self-management for current pain and future pain, we've got to step back. Start low and go slow. Sprinkle, figure out where they're at. Grade it over time. And if we can get good at that, if we can use this as not a standalone intervention, but as a piece of the package that as we build our therapeutic alliance, as the patient moves better, feels better, gets stronger, builds trust in us, we can start prying out some of those negative beliefs and maladaptive beliefs and replacing them with good, solid information that really drives patient forward. We can go a very long way to reducing the future risk of chronic pain in these patients. At the end of the day, I really believe that our current pain epidemic and our worsening pain epidemic stems from a fundamental cultural misunderstanding of the experience of pain. Human beings are messaged all day long with stuff that promotes fear, takes away locus of control, and promotes this idea that you need someone else to give you a thing to heal your body. It is our job as physical therapists, as clinicians, as people that have access to not only patients but the community, to get out there and spread the different message, to figure out when, where, and how to get this education out there, to change the noise to sound ratio and get patients, humans, to think differently about their bodies. This is a great study, but we've really got to realize that while the way the education was performed here didn't change the course of care over 3 to 12 months, that doesn't mean that the answer to this problem isn't changing the culture's understanding of pain. That's where all this lives. We've got to get out, educate. We've just got to get better at doing it and figuring out how and where to dose it. All right. Thanks for listening. At the bottom of this, I will post, I'll post the article. I'll also post the article talking about that pickup tool, which might be a nice thing to integrate into practice. Otherwise, thanks for listening. And there's one more chance to catch our spinal thrust manipulation course this year in South Dakota on December 15th and 16th, and then we'll be back at it mid-January 2018. And the next cohort for our persistent pain comprehensive management starts in February 2018. So if you've got any interest in either of those, check out the links below. And I will see you here next time and hope to see you out on the course circuit in the future. Have an awesome day in clinic, everybody. Thanks for listening.